Good afternoon, everybody. I'm here to introduce Dr. Becky Bulow. She is an allergist and an immunologist with Children's Hospital of Wisconsin, and she actually practices up in Neenah solely. As some of you may know, Children's has an outreach to Neenah, and they're just bringing us new doctors every day that are staying there. She also sees adults, yes, with allergy issues. We brought her to speak mainly from the pediatric department, kind of focusing on our outpatient antibiotic stewardship, because many kids and adults get labeled with penicillin or amoxicillin allergies that probably aren't really allergic. But then when they enter into your clinic or the hospital sick, and you see that allergy, you tend to shy away from prescribing any Beta-lactam antibiotic when probably you don't need to. So she's going to educate us and set us straight on that so that we don't always grab the Z-Pack. So, all right.
Thank you very much. That was a very nice introduction. No, I have a bigger friend. Yeah. Can you guys hear me okay?
Yep.
Pretty good. So thank you, Dr. Naras. Yes, to let you guys know, I do see adults. I do see kids. I do see inpatient consults at Theta as of now. I don't know if you guys have allergists that consult in the hospital here. Is that, I've never asked when I've been here. No? Okay, just curious. So if you guys, has anybody ever performed like a desensitization to an antibiotic here in the hospital? I don't know if some of you guys are intensivists or hospitalists or have privileges here. Okay, well, we'll talk about all of that stuff. But if you ever have a question, you can just, please feel free to call me. I'm happy to talk over the phone about anything. And she's right, I do solely just live in Neenah, so I don't transplant from Milwaukee. I'm in Neenah full time. All right, so now we're gonna focus on beta-lactam allergy. And is your patient truly allergic? Whether they're a child or adult, I'm gonna generalize for the most part during this talk. So I have no financial disclosures at all. And here are my objectives, so I don't need to read them to you guys. I think hopefully you'll be able to follow how the presentation is presented, how I want to kind of talk about broad definitions, some epidemiology and natural history about beta-lactam allergy. I think some of you probably are interested really in the cross-reactivity data between all of the beta-lactam antibiotics, how to evaluate beta-lactam allergy if you're in the hospital, if you're outpatient, or how I do it as an allergist. Obviously, I have a little bit more tools than you guys have available to you, and then when really you should refer. All right, so the definition of an adverse drug reaction is very, very broad. So really, it's any noxious, unintended, or undesired effect of any drug, whether it's prescribed for prevention, prophylaxis, treatment, or diagnosis. And the reason I talk about this is with the terminology that I use throughout the talk, I'll be using adverse drug reaction versus allergy, and those actually are not synonymous terms. So when I have somebody come to my clinic, or if somebody's in the hospital, if they're labeled with an adverse drug reaction, I think it's important to know, okay, how do we classify that adverse drug reaction? So how I think about it are there's basically type A and type B reactions. So type A reactions are the majority of the reactions that people have. And these can happen really in any patient. Usually you need a sufficient dose of the medicine. You need to be exposed to the medicine, and it's more of a predictable outcome, right? So if you have somebody that's on NSAIDs and they get gastritis, right, that's something that we all know about and is really a known quote-unquote side effect. But I would classify that as a type A type of reaction. The more, or the less common reactions that I see the majority of the time are the type B reactions. So they're more of the bizarre reactions, and this is usually about 1 in 10 of all adverse drug reactions. These are usually more in specific patients or susceptible patients. They are typically unpredictable. So when you guys give amoxicillin, you can't predict if they're going to have a reaction or not. And that's actually subdivided into some other categories. So like an exaggerated sensitivity can happen. So if somebody gets 1 dose of aspirin, and then let's say they have tinnitus. That's not a typical side effect, so that's more of an exaggerated sensitivity, so that's a type B reaction. There's idiosyncratic drug reactions, so if you have somebody with G6PD deficiency and you give them primaquine, they can't really metabolize the medication as well. And then the one in yellow is more of the immunologic drug allergy. So when I talk about drug allergy for the rest of the talk, that's the kind that I'm talking about. So when we think about immunologic drug allergies, this is really about 6 to 10% of all adverse drug reactions, and I think the biggest thing is it's the biggest percentage of fatal reactions. So up to 10% of people can have fatal reactions to drugs. And I'm sure all of you remember Jellincrons from training, something that you look up on UpToDate. And this is actually something I just go through in my head when I see somebody in clinic. How do you really classify the patient? Is it type 1 or IgE mediated? So that typically occurs within 2 hours of the dose of the medicine, whether it's IV, IM, or PO. And the classic is having hives or anaphylaxing. Type 2, which is probably the least one that I see in clinic, is if you have an IgG-mediated cytolysis. So that can be hours to days after taking the antibiotic or the drug. An example is like hemolytic anemia. Type 3 reaction, something we commonly see, I feel like, in kids, is immune complex mediated, so serum sickness-like reaction. And that usually happens 7 to 21 days after the course of the antibiotic, so really getting a good history is important. And then type 4, which is more of the delayed type hypersensitivity, that can be days to weeks to even months later. So something like Stevens-Johnson's, TEN, or DRESS. This is kind of what I go through, or the algorithm I go through in my head. All right, so for the rest of the talk, we're going to talk about beta-lactams. And just to remind everybody, the antibiotics that are in the beta-lactam class or group are penicillins, so like amoxicillin, cephalosporins, so all the generations of cephalosporins, carbapenems, and monobactams. So as you can see here, if you look at the structure of all of these, this is why they're called beta-lactams, because they have a beta-lactam ring. But they look a lot different from each other if you just look at them structurally, which is important here in a little bit. So a little bit about the epidemiology and natural history of having beta-lactam adverse drug reactions. So as you probably all know, that penicillin is the most commonly reported antibiotic drug allergy in the United States. About 10% of the population will tell you that they are allergic, and usually over 90% of those patients can actually tolerate it. So if you think about patients that are coming in, about 1 in 10 truly have some sort of allergy to that antibiotic, which is pretty low. It's actually, there was a recent study showing that it's documented in about 8% of people using healthcare in the US. And the next antibiotic that's listed is cephalosporins. So of course we have the beta-lactam group, right? You have the penicillins and then the cephalosporins. Eric Macy is a big drug allergist out at Kaiser Permanente, and he published that less than 5% of people will have any sort of reaction if you actually perform an oral drug challenge in the office. So people are labeled, but are there a lot of people truly allergic? Not very much. So this also is a huge significant healthcare problem. Obviously we know that because there's antibiotic stewardship all over the place. There's actually a pharmacist at ThedaCare on the campus that I am. That's what he does, is antibiotic stewardship, and that's it alone, and he's a full-time pharmacist. So this is obviously a problem that we know about, but these are the side effects from it, right? So you have increased healthcare costs, your length of stay is longer in the hospital, increased hospital utilization, increased rates of nasty infections like C. diff, VRE, MRSA, actually poor clinical outcomes, because you can't always use the antibiotic that's the best choice, or you feel like you can't. And then obviously increased toxic side effects from the alternative antibiotics that we use. So if you have somebody that, for instance, could use amoxicillin, you end up using something like clindamycin or something like that. Those are things we have to be aware of, and hopefully I can give you guys some tools to help decrease these significant healthcare problems. So, as Dr. Grass mentioned, antibiotic stewardship is definitely on the rise. The Board for Internal Medicine Foundation initiative is actually don't overuse beta-lactams in patients with history of penicillin allergy without appropriate evaluation. So I'll touch on what that means, but I think it's more about being proactive about the patients that have that laundry list of allergies on their allergy list, and really trying to get those off of that list or have them evaluated at least before they become sick and need the antibiotic. So there's also a National Penicillin Allergy Day, and this is really to raise awareness about being labeled penicillin allergic, really create awareness throughout healthcare communities, hospitals, clinics, and really you need to dive into what's the patient's true allergy. All right, so a little bit more about the natural history, and now I'm going to go to the type 1 type of reaction, or IgE mediated. As an allergist, we love IgE, so that's for the most part what I'm going to focus on. But if you have somebody that comes into your office or your hospital and they say they had hives when they took amoxicillin or penicillin, and that was about 15 years ago, it's pretty likely that they probably outgrew it. So 50% of patients lose their IgE 5 years after their initial reaction and 80% 10 years after. So that's something that people typically outgrow. And just so you know, if you are newly exposing somebody to penicillin, the risk of really having a true allergy and anaphylaxis is incredibly rare. Any questions about that stuff, guys? Or any comments? And if you have questions or a comment, please feel free to interrupt. So I'm going to talk a little bit more now about pathophysiology and cross-reactivity, which pathophys is not all of that exciting, probably for you guys, but just to kind of tell you what I think about when I see these patients, and just to give you a couple of pearls to take with you. So from your immunology days, here's some definitions about some terms that I'm going to use. So a hapten actually is this very small molecule that needs to bind to some other protein to actually become immunogenic. So if you have a hapten by itself, it doesn't cause an immune response. And something that's different between an immunogen and an antigen, the immunogen actually produces an immune response. So I'll use these a little bit in context for beta-lactam allergy, but an antigen is actually the molecule that's capable to binding to the product of the immune response made by the immunogen. So I think something to take away with is a hapten is not immunogenic unless it's linked to a self-protein or a protein. Because for penicillins, the beta-lactam ring is a hapten. So it's not immunogenic by itself. What happens is that if you're exposed, it binds to a self-protein, whether it's albumin in the body or IgG, it becomes a reactive intermediate, and then you actually get your immune response. So I think this outlines it a little bit better. So penicillin by itself is chemically inert. Until it's physiologically in the body is when it becomes, what we say, the ring becomes unstable. And then it's able to bind to proteins to form antigens or immunogens. And then for penicillins, specifically, the major determinant or major antigenic determinant that's made is penicillyl oil. Okay, that's about 95% of what the drug makes after it haptenates and becomes an antigen or an immunogen. About 5%, or the rest of the antibiotic, becomes the two minor determinants, so penicilloate and phenyloate. Not that you have to remember those specifically, but I'll talk about them when I talk a little bit about skin testing and allergy testing. You don't want to miss the patients that have minor determinants because that's usually more associated with clinically associated with anaphylaxis. So even though they're minor determinants, they're a big deal. So a small percentage of patients with penicillin allergy actually don't react to the beta-lactam ring haptenating to a protein and causing or producing IgE to those determinants. A very small percentage of them actually have immediate symptoms with ampicillin or amoxicillin, and really that reaction is to the R group side chain. So if you remember me showing you those different chemical structures, it's not the ring, it's actually the R side chain that you can have problems with. And I think something that's important is that, I don't know if you guys can see this very well, but with amoxicillin and ampicillin, the cephalosporins that have a similar R group side chain, these are all first and second generation cephalosporins. So they're not typically third, fourth, and fifth generation cephalosporins, it's usually the first and second generation cephalosporins. So I thought this table was kind of nice to show you which cephalosporins have similar R groups. Because for cephalosporins, the allergy or the IgE is actually against the R group side chain. It has nothing to do with the beta-lactam ring. And here's a nice little chart down here, and you can find that online. It's not that there's limited data or the ones that can cross-react with each other. But if they have similar R chain or R side groups, we'll talk about that in a little bit about should you use those antibiotics or not. I think this basically just reiterates. If you have cephalosporin cross-reactivity, it's usually within the same cephalosporin group. Doesn't mean it's a first or second generation, but again, it's R group side chain. So it's really a true IgE-mediated reaction, but it has nothing to do with the beta-lactam ring. So just to touch a little bit on monobactams, aztreonam. So this is actually safe to give in penicillin and cephalosporin allergic patients, except for ceftazidime. So these have similar R groups. So if somebody comes in and says they have a ceftazidime allergy, depending on what they say it is, you should never give them aztreonam or think twice before you give aztreonam. And the way I remember it is because ceftazidime has a Z, so does aztreonam. So that's the only cephalosporin or penicillin that you have to worry about if somebody comes in with an aztreonam allergy, which isn't very often. All right, so I think this is probably one of the most useful tables that I have in here, really to show the cross-reactivity of beta-lactams with penicillins. And this is for IgE-mediated allergy, okay? So other penicillins, there's complete cross-reactivity. So if you have a penicillin allergy, you should avoid penicillins. First and second generation cephalosporins, back before the 80s, it was a little bit higher in terms of cross-reactivity. Now, more recent data, probably in the last couple of decades, is about 2% of the first and second generation cephalosporins cross-react with penicillins. Probably from that R group side chain that I showed you guys with ampicillin and amoxicillin. Third and fourth and fifth generation cephalosporins, pretty low. Carbapenems is pretty low, and monobactams is nothing with penicillins. Just remember ceftazidime for the cephalosporins. Is this useful? Do you feel like this is useful? All right, so moving on to like the drug evaluation piece of things. I can't stress enough how important it is to talk to the patient. History, history, history. And a lot of patients don't remember the reaction, or I will say a lot of parents don't necessarily always remember the reaction, especially if it's far removed from it. But always asking the patient is very, very helpful. Obviously knowing which drug, so in this case we're talking about beta-lactams. What antibiotics have they tolerated since that reaction can be very, very important. Because I have had patients in my clinic say, you know, I have an amoxicillin allergy, but I take Augmentin all the time. Oh, okay then, right? So that's really important to know before you jump down the path of doing skin testing and drug challenges and all of that stuff. So really knowing what antibiotics they've tolerated since the reaction. Timing and duration of the reaction. Again, if it's IgE mediated, if it was more than 10 years ago, it's unlikely that they'd have another clinical reaction, right? Because 80% outgrow it. Did they require evaluation and treatment by a provider? So if somebody tells me they had a reaction to an antibiotic and they ended up in the ICU in a burn unit, well, that makes me think of Stevens-Johnson's or TEN or something bad. So always knowing, did they seek medical care for that reaction, or was it that they had a rash at home and it went away and it wasn't a big deal, per se? And then obviously what the symptoms were with the reaction. So for patients that have an IgE-mediated reaction, hives, swelling, wheezing, coughing, vomiting, and those are usually within minutes to a couple of hours of having the antibiotic. It doesn't always have to be the first dose if it's their first course of that antibiotic. Did they have joint swelling, fever? What did the rash look like? In this day and age, we actually have it's wonderful to have the phones because patients take pictures. So looking at pictures. Again, did they have blisters on their skin? Did they have mucocutaneous involvement? All of those things are really important because that helps me decide, do we go down the road of allergy testing? Do we do drug challenges in the office? Or do we say, you know, it sounds like you had erythema multiforme, or maybe you had Stevens-Johnson's. We don't ever want to give you that antibiotic or that drug again. Obviously, physical exam, if it's acutely occurring, that's usually not the case. Medical record review, so a lot of people will say that that reaction happened, whatever, I don't know, look in my son's medical records or look in the medical records, which I get a lot. And then what are their other allergies? Are they atopic? their past medical history. So really getting a history and finding out what truly happened, and then knowing what type of adverse drug reaction it was. So was it type 1, type 2, type 3, type 4, kind of that Jelen-Coombs classification, because that really helps me on how I'm going to perform my evaluation. So what can we do, or what can you guys do in your clinic or in the hospital, right? You don't always have an allergist at your disposal. You guys are all very smart people, so what can we do in the hospital if we feel like they need this antibiotic that's on their drug list? If you can be proactive, I have some patients that have 60 allergies listed on their medications. So going through all of those, my MA does not like doing that. And obviously I go through them again too, but really, is it an adverse drug reaction? Like they had diarrhea with an antibiotic? Okay, right, that's a type A type of adverse drug reaction. That's not something I'm worried about having them anaphylaxed to. So knowing what the reaction is and really having it documented well can be really helpful. But I think something that you guys can do in your office or in the hospital if you feel comfortable is doing oral drug challenges or IV drug challenges in the office or inpatient if it's low risk. So again, if you have somebody that has an amoxicillin allergy, and they said they had a rash when they were a kid, and let's say they're 60, and if you're in a setting where you feel comfortable with managing anaphylaxis, that's not always the case, probably more inpatient than outpatient, you could give like a 1090 dose. That's typically what I do when I do an oral drug challenge to see if they actually tolerate the antibiotic, is I give 10% of the final dose of the drug, wait 30 minutes, monitor for any severe reaction, give the last 90% and watch another 30 minutes. Allergists do 1090s a lot. That's kind of the terminology that we use to do like a graded challenge. So those are things you can do if you feel like it's a low risk reaction if they've had to previous drugs. One other thing I will say is I get a lot of patients in my office saying, I want you to allergy test me to ibuprofen, to doxycycline, to gentamicin. Unfortunately, there is only one drug we can allergy test for, and that's penicillins. And that's to look for any IgE-mediated reactions. So other stuff, typically we either do graded drug challenges, which I'll talk about in a little bit, or we do a risk assessment. Can we do that in the office? If they had a breathing tube when they had a reaction, probably something if they truly need that medicine, then we do a desensitization inpatient. There is blood testing out there for IgE for penicillins. I would not recommend ordering that. It is not sensitive nor specific. It doesn't really help. So if there's somebody that you're worried about having an IgE-mediated penicillin allergy, skin testing is really more reliable. And typically, I would say I would recommend an allergy referral for the testing piece. We do it often. It takes a lot of resources. It takes some technical skill. We watch patients. But if you really want to have drug challenges or desensitizations that you're not comfortable with, you can always send them to an allergist. So again, for penicillin skin testing, it's only good for IgE-mediated allergy, and I will tell you that the skin testing is really, really good to rule out the drug allergy. I'll tell you here a little bit about who I think about testing and who I do not think about testing, and then I'll talk a little bit about the testing and what it entails. But people who you do not allergy test is people with a history of DRESS, right? That's not IgE-mediated. That's that type 4 reaction that I was talking about. So people should stay away from that antibiotic or that med. Stevens-Johnson's serum sickness-like reaction, which is a type 3, hemolytic anemia, bullous skin diseases like bullous pemphigoid, bullous pemphigus. Those are things that the allergy testing that we have for penicillins is not helpful to identify or evaluate for those types of reactions. Who we do allergy test is people that had rash. And not a scary rash, right? Like a low-risk rash, like it was red, maybe a little bumpy, but it wasn't painful, it itched. IgE-mediated symptoms, which I think I've probably beaten to death. Feel of allergy, but fear of allergy, but can't recall symptoms. So a lot of people will come in and say, my mom said I have an amoxicillin allergy, I haven't had it in 40 years, but I've avoided it because my mom said I had the allergy. And I will tell you also that any age patient can be skin tested. There's not an age limit in terms of young or old. So these are patients that I would perform allergy testing on for penicillins. And these are patients I would not, because they don't fall into that type 1 allergy category. So when we perform penicillin skin testing, we actually perform the testing to the major determinant, which is penicillin oil, and that's actually commercially available as pre-pen, so it's manufactured. And then we also do skin testing to penicillin G. We do not typically skin test to the minor determinants, even though those are the ones I told you are more related to the anaphylaxis piece. Those aren't commercially available actually at all in the United States. So you're probably like, well, why don't you skin test for those if they're kind of the higher risk ones? The nice thing about the skin testing, and there's been numerous studies on doing penicillin skin testing with pre-pen and pen G, is that the negative predictive value is about 95% when you just perform the skin prick testing piece. So I don't know if any of you have been allergy tested or seen this, but this is what we use to skin prick. And we usually perform a negative control, a positive control, and then we also do the pre-pen and the pen G in duplicate. And if that's negative, again, a really good negative predictive value, right, to rule out something, because it's only got a 5% chance false rate, we add intradermals. So kind of like a TB skin test is when we do intradermals. So if the skin testing is negative to those determinants, then we add intradermal testing to those same antigens, pen G and pre-pen, and the negative predictive value almost approaches 100%, which is really great. If you have a positive predictive value of that test is not as great, so about 50% of the time it's accurate. So if it's positive, not as great, but if it's negative, typically I give people a dose of amoxicillin in my office and watch them for 30 minutes, and I've never had anybody react when they've had negative skin testing. So it's a long, drawn-out process. Unfortunately, it takes a couple of hours. But this can be really helpful to rule out the allergy. All right, any questions, guys? I'm just going to talk about, in terms of if you see somebody with penicillin allergy, cephalosporin, how do I evaluate that, or how can you guys evaluate that, or if you need any help, I'm happy to help. Obviously, because you guys don't do the skin testing piece of things. But if I have somebody that comes in with a penicillin drug allergy, labeled as penicillin allergic, I will tell you amoxicillin is usually all over my patient's charts. I perform the skin testing. Again, it's not optimal to skin test an 18-month-old with intradermals, right? Like, who wants to place 5 TB skin tests on a young child? But we do that if it's something that we need to do. And long story short, if it's negative, then what I do is I either give the full dose. Some of my partners give a graded challenge like I was telling you about, so 10% watch for 30 minutes and then 30% of the rest of the remaining dose. If the skin testing is positive, then I say you should avoid that drug, use an alternative if you can, and if they need it, then we perform a desensitization. So the reason I have not allergic and allergic under there is that if you desensitize somebody to an antibiotic or a drug, and you give them a course of it and they stop it, they're still allergic. You can't just give it to them, okay? If you have somebody that you do a graded drug challenge, like the 10% and 90%, they're usually not, I would unlabel them as allergic and they can tolerate it and have a course whenever they need it, if that makes sense. Usually if I suspect an IgE-mediated drug allergy, I'll say, oh, no, we can retest you in a couple of years. Because, right, most people lose that IgE, so at some point, their test should go from positive to negative. So just to talk a little bit about desensitization, like I said, what happens with desensitizations is that we give increasing amounts of the drug, and they're able to usually tolerate it after desensitization. We usually have them in the ICU, monitored, because you can have an anaphylactic reaction. That's a possibility. It's pretty low risk, not low risk like a great challenge, but what happens is the protocols that are out there are usually about 12 to 17 steps. So you give very, very, very small amounts every 15, 20 minutes. We usually start with 1/100,000th of a dose. For graded drug challenges, those are usually like 1 or 2 steps. I would say maybe 2 to 3 steps. I guess there is a fuzzy line in the allergy world about what's a graded challenge and what's a desensitization. But I usually use 2 steps if I do a graded challenge, because if they pass a graded challenge, then they're no longer allergic and they can have that drug whenever they need it. or a desensitization, they can't miss doses, they need to go ahead and take that medication, but once they stop that course, they need another desensitization or need another evaluation because they should still be labeled as allergic. Does that make sense? Okay. All right, so what if your patient isn't allergic to a penicillin? Right, if they're allergic to a penicillin, if it's a really low risk reaction, you can do graded challenges in your office. I don't know a lot of people that do that just because of having epi and it takes up a room, it's a long time. People don't necessarily always feel comfortable with treating anaphylaxis. But if somebody comes into your office and they're allergic to a cephalosporin, what can you do? So typically, 2% of people truly react to a cephalosporin if they're penicillin allergic, which I already mentioned. But if you need a cephalosporin, if it's first or second generation, typically in the allergy world, we recommend skin testing just because of that cross-reactivity I was telling you guys about the R group. And if they have a negative skin test, then they can go ahead and get that medication. If they have a positive skin test, again, you try to do alternative medication, a graded challenge if it's still low risk, or a desensitization if it's a severe reaction. Now, if it's a third or fourth or fifth generation cephalosporin, that's fine to give. So if you have to give a cephalosporin in a cephalosporin allergic patient, you obviously want to avoid the ones that have similar R groups. So again, that's really out there in the literature. You're able to find that even asking your friendly pharmacist if your inpatient can help you. So if it's a history of a severe reaction, you usually say give an alternative. Or if you think it's low risk, then you can still do a graded challenge. Not a lot of people do graded challenges. I promise I'm almost done with all of the charts here, guys. And then if you want to give a penicillin in a cephalosporin allergic patient, this is kind of the algorithm that I go through. You want to avoid forms with similar R groups. So I kind of copied and pasted just those rare ones where amoxicillin and some of the cephalosporins or ampicillin and some of the cephalosporins cross-react with that R group. Usually I would recommend penicillin skin testing also. Negative, you can give your dose, and positive, then you think about alternatives for desensitization. All right, so I think this is kind of the gist. In terms of clinical practice, somebody comes in your office or my office with penicillin allergy. I usually have them avoid all penicillins until allergy testing can be performed. Again, if it's low risk, you can do a drug challenge in your office or in the hospital. I usually have people, if they have a penicillin allergy, avoid first and second generation cephalosporins until we can perform the testing because of that R group side chain is the antigen. Even though it's low risk and it's the minority of patients, that's what I do in clinical practice. If the patient, obviously the penicillin allergic patient, comes in and needs a carbapenem, if skin testing is available, so let's say it's something that's on their drug allergy list, they don't need that acutely, I would skin test them. If no skin testing is available, so let's say you need that to treat somebody in the ICU or inpatient, then I would do a graded challenge. I would just do a 10-90, 10% of the dose, watch 30 minutes, 90% of the dose. And then anybody that's penicillin allergic can have monobactams, third, fourth, and fifth generation cephalosporins without problems. I just give the drug to those patients. All right, so when to refer. If you have questions about the testing, do you think this person may need a desensitization, drug challenge? Is it IgE mediated? Is the reaction unknown or is it remote? Anytime you're just really unsure, you're like, I can't get a clear picture of what's going on, or if the drug is really truly necessary. So I had a patient that needed Bactrim prophylaxis for, I think she had a replacement knee and she was septic a couple of times with a weird bug and she needed Bactrim. I don't really like Bactrim because I feel like that one people have more reactions to, but based on her history, she had hives. And it was for a few days while she was on the Bactrim. And there's no skin testing for Bactrim, so we talked about doing a graded challenge in the office, which we did. She didn't have immediate reaction, but the next day she ended up having hives. So when I do the drug challenges in the office, I tell people not to take any new drugs for 5 days afterwards, just so we don't introduce something else that may be causing a reaction. Because you always want to tell people that may have a delayed type of reaction. So I usually tell people 5 days. So she called when we came in, and it was pretty significant. And she hadn't changed anything else. So I said, you know, I don't think you should have Bactrim. So that's just kind of one example of what we do in the office. So do you guys have any cases you want to talk about? Anybody have a case that's interesting, or give a scenario that you're like, I'm not sure what I would do? Yeah, go ahead.
I was just wondering, how do you do a 1090 challenge with oral medication? How do you?
With oral?
Yeah.
So luckily for us at the Children's Hospital, they have liquid versions. So we just use the liquid. It's kind of terrible if you have to give them like 4 teaspoons of something gross. I usually have teenagers that are like, I don't want to take that. But we typically do liquid. That's a good question. Anybody else have any questions? Okay, I'll tell you one other case that I had then. So I was a fellow down in Milwaukee, and I had a patient that had neurosyphilis. We all know that penicillin is what you need to use to treat neurosyphilis. I got a call from one of the residents, and he said, well, he just had hives with penicillin, and it was a long, long time ago. I said, okay, and I was a fellow. I think I was a first-year fellow. So obviously I came into the hospital, and this poor guy was losing vision in the one eye that he had. He had a glass eye, actually, so the one eye that he could see out of, he was losing vision from, so he needed emergent treatment. And I went in there and I talked to him, and he's like, well, no, when I had penicillin, I needed a breathing tube. Big deal, right? So long story short, we admitted him to the ICU. We did a desensitization for penicillin. And I went and actually spoke with the team afterwards and said, you know, we're going to transfer him to the ICU, do the desensitization. I gave them the protocol, all that stuff. And I said to the resident, I'm like, did he tell you that he had hives? He's like, no, that was just in the chart. So again, I can't stress enough, asking the patient, a lot of times they remember. But I'll have a lot of people come to clinic, be like, you know, say this is what's on the allergy list, so like, that's not what happened at all. So don't always believe documentation. And I felt bad for him. I think he saved the vision in his eye. But anyway, that was probably one of the most interesting cases I had for drug allergy stuff. Any other questions, guys? Or yeah, go ahead.
Patient coming with history say, my dentist told me that I'm allergic to Novocaine. And what do we do?
So what do you do with that? Good question. So even though this isn't about anesthetics or canes, for patients, typically if they're having a procedure at the dental office, you ask what happened. Because if there's epi in there with it, because they usually use that along with their injections, a lot of times people will be like, you know, my heart raced, felt a little dizzy. It's probably from the epi. Because having a true IgE-mediated allergy to any canes, whether it's the amides or esters, is incredibly rare. So for people, we do have skin testing for that stuff. So you can refer them for that. And if that's negative, then we actually challenge them in the office to the cane that they're having problems with. Is that helpful?
Yeah. I know they normally don't use a Novocaine anymore, but they still tell the patient it's a Novocaine they're allergic to.
Yeah, so depending on the cane, and there are some that cross-react with each other and some that don't cross-react. So a lot of times I'll even say, like if they come in and they don't want to do the skin testing and the intradermal testing because it's very similar to the penicillin type of procedure. And if you have a little kid, most parents are like, I don't want to do that. I don't want my kid to be stuck with needles. So then I say, you know, if you have, off the top of my head, if you have this cane that you're allergic to, this one should not cross-react, or can you find out from your dentist what your dentist uses, and we can maybe find an alternative that doesn't cross-react with the one that you have the allergy for. And then I say we can do the evaluation when the kid gets older, or when somebody gets older. I mean, if it's an adult, I'll do the allergy testing. I think I've skin tested maybe 2 patients in my group, not a lot. But we do test doses in the office just like we do for penicillin.
Is there any type of skin test we can do it immediately before procedure? Say, patient coming for labor epidural, and then give you a history that I'm allergic to local anesthetic. Were you able to do any skin test?
Like acutely then?
No.
I mean, if you have an allergist around here that has the antigens, maybe they would do it inpatient, but that takes at least 20 minutes, and the skin testing isn't sensitive, so we have to do intradermal, so the process is like 2 hours. So if that's something, and of course, right, it's not always on their allergy list, they kind of bring that up last minute. And if it's something on their allergy list, great. But skin testing a pregnant patient is also not without risk, especially if they anaphylaxis. Even though it's low risk. You might have some partners that would skin test pregnant patients. Because of the risk to the fetus, like if your blood pressure drops, what about the placental blood flow? So, unfortunately, it wouldn't be something quick if that were the case.
Thank you.
Yeah, sorry. I wish I had a magic answer for you, or a magic bullet. Anybody else have anything? Oh.